So we've heard a little bit about the congenital world and at the pediatric level. Dr. Lin heads up our adult congenital program. And so what he's going to take us on a journey is after the first intervention takes place and they move into adulthood, what are we actually going to do at that particular point in time? And that's really what HUIE has made his reputation on. So take us away, Dr. Lin.
Great. Okay. So I see everybody sort of sitting like this. Okay. For those of you who have been here for previous MMIs, this is going to be a little bit different because I'm actually going to make you participate. So everybody lean in, okay, because you are going to actually be reading these studies now. So these are my disclosures. So I'm going to skip some of the things about talking about the magnitude of adult congenital heart disease because John's actually already done that really, really nicely. But to give you a flavor of what is coming up next and what your choices are going to be as far as diagnoses, these are the diagnoses that we're going to cover. So you've already seen some of this information, but in dark gray, these are admissions to hospital in adults with congenital heart disease, and in light gray, these are children with congenital heart disease being admitted. And you can see now, at this point, we probably have as many adults with congenital heart disease being admitted as children with congenital heart disease. In fact, actually, I'm carrying a census of about 8 patients right now here at Houston Methodist Hospital with congenital heart disease. At this point, that makes sense, right? Because by 2020, we're expecting that there will be about 2.2 million adults with congenital heart disease in the United States alone. So a lot of us actually think of this as a tidal wave. And if you think about the history that John showed you, it makes a lot of sense. Because with the advent of cardiac surgery, we have created a completely new population of patients that we may not be prepared for, just as Mickey wasn't prepared for when he actually became the sorcerer's apprentice. And it's kind of fun to actually think of it this way, you know, as patients being like the broomsticks and the buckets, but the reality is there's a serious reason for why we do what we do and why we work as hard as we work. Because at this point, we like to tout the number 90% of kids will survive to adulthood. And this is something that came up on my Facebook feed because I'm on a lot of congenital heart sites. So this is a neonate, for those of you who don't have a lot of experience with this, and this is what mom said on the post. Today was my handsome heart warrior's funeral. He survived 8.5 hours. His diagnosis was hypoplastic left heart with intact atrial septum. We donated 2 healthy heart valves to other heart families, and I will always be proud of him. So I put this up as a reminder that in order to get a patient like this to 18 years of age and into my clinic, there are hundreds, if not thousands of hours, millions, if not tens of millions of dollars spent to get these patients to adulthood. And so it behooves us to have at least a little bit of information when we see these patients on how to actually diagnose that. And I'm hoping that today will get you there. So the truth of the matter is they're going to show up to us in the most unexpected manner. And most of the time it's going to be when they're sick because, and unfortunately for most of us, it's still alphabet soup because we don't do this on a daily basis. Worse off, before they show up sick, they're going to claim that they are asymptomatic. Well, I'm going to challenge you at this point to actually try to figure out how you're going to determine whether they're symptomatic or not because they were born with this by definition. Right? So one could actually argue they have no idea what asymptomatic actually means because they have no normal frame of reference. So be very careful when you hear that word, I don't have any symptoms. So let's start with our very first case. So this is a 29-year-old man who is quote-unquote asymptomatic until he wasn't. He presents with severe heart failure and is in borderline shock. This is what we know about his history. He had emergency surgery, emergency procedure as a neonate, and then he had heart surgery later on at 3 years of age. And this is what his echo looks like. So what do we see here? Any thoughts? Shout it out. What do we think this is going on? Okay, I hear somebody saying VSD. VSD, okay. Anything else? Any other thoughts? Right heart's huge. Okay. All right. So this is typically the problem that I end up having when I'm looking at an echocardiogram. So it's a little hard to do this in adults, and it's hard to understand the ventricular-arterial relationships, which is what's really crucial here. So let's take a look at the CTA. And what I'm going to do is I'm going to walk you through this and show you the salient points. So this is the arch of the aorta. This is the very enlarged PA, right? And then as we come down, we can actually start to see this, okay? What is that structure? we can actually start to see pulmonary veins coming into it. And then we see it connected to this structure. And if we actually look at where it goes to the anterior ventricle. Interestingly, for the people who said VSD, that's actually true. He does have a device there. And then if you follow this down, we look at the IVC. The IVC starts to come over and connects to this structure, which connects to the posterior ventricle. If we follow the posterior ventricle, it connects to this structure, which we know is now the pulmonary arteries. So, what are we dealing with? A, truncus arteriosus, raise your hand. B, ventricular septal defect, which is partially true, raise your hand. C, tetralogy of Fallot, raise your hand. Or D, transposition atrial switch, raise your hand. Great. So, fantastic. So that is exactly what this is. This is transposition with atrial switch. So let's look at the salient points. So this is the systemic right ventricle, which is the anterior ventricle. This is the tricuspid valve, because remember, the valves follow the ventricles morphologically. And then this is the mitral valve, which goes with the pulmonic left ventricle. And finally, you can see the pulmonary veins, which come into this structure, which is baffled, of course, into the systemic atrium. Okay? Let's look at something else here, which is basically, this is the anterior aorta, which is anterior and to the right. Okay, so this is D-transposition. And then this is the left coronary. That's how you're always going to identify the aorta on cross-sectional imaging. If you can see the coronary on echo, even better, because that's what you're going to help to identify. So for sonographers, this is where you really need to do your subcostal sweeps to show the ventricular arterial connections, right? Because otherwise, no one will ever have a clue looking at the parasternal long or the apical 4 about what's going on. And then, of course, this is the pulmonary artery. As I showed you, it actually connects to both the right and left pulmonary arteries. So transposition of the great arteries, what are we actually talking about? So remember, this is what it looks like at birth. This blue circulation goes to the aorta, goes through the systemic circulation, comes back blue, back to the right atrium. Likewise, the red circulation goes to the pulmonary artery, goes through the pulmonary circulation, comes back red to the pulmonary vein. So this is clearly not compatible with life. So what did our patient have as a neonate? Well, he had a Raschken septostomy, which is creation of an atrial septal defect using a catheter technique. And that is what you have to do in these patients who have an intact atrial septum in order to get them through the first several days of life. And then what was done back then was an atrial switch, which is to take the blue blood and baffle it over to the left atrium, which then goes to the subpulmonic left ventricle, goes to the pulmonary circulation, and then baffle the pulmonary veins to the right atrium that goes to the systemic right ventricle and goes to the aorta. So the problem is at this point that our patient now has not only a systemic RV that is under pressure overload, he also has, as you know, at least moderate to severe tricuspid regurgitation. So now he has not only pressure overload, but he also has volume overload, which these patients do not tolerate. And they will say they're asymptomatic, just like some of our mitral regurgitation patients, right until they crash. So once you start seeing that, you have to be very careful because they probably need to be referred for advanced heart failure therapies at that point in time. So with transposition atrial switch, beware of heart failure, beware of any evidence of tricuspid regurgitation, beware of atrial arrhythmias because they can lead to sudden death, and be aware that these patients may be subject to the risk of sudden death irrespective of whether or not they have atrial arrhythmias. So what's this? And again, I'll take you through it to give you a few hints. So this is the arch of the aorta, and this is interesting. So we have the pulmonary arteries draped over the aorta, and you see a coronary coming off of the aorta right there in the center. So it doesn't quite look like our last patient. Okay, so let's follow our ventricle. So the posterior ventricle gives rise to that central vessel, which gives rise to the coronary arteries. So our posterior ventricle goes to the aorta. And then our anterior ventricle goes to the pulmonary artery. And again, I want to emphasize that it's draped over the aorta, which is a little unusual. So that is transposition of the great arteries with arterial switch. So that is the contemporary repair, which was taken on in the mid-1980s, pretty much general across the country. So this is what has to happen. It's conceptually what makes sense, okay? And that is what you're going to do is you're going to switch the aorta and the pulmonary arteries. But the key element, and this is where we have to be very careful, is that the surgeon has to take the coronaries off of the old pulmonary artery and put it onto the aorta. And what this does is potentially puts the patient into a situation where the coronary arteries can potentially kink. And then the other thing that the surgeon has to do is has to pull the pulmonary artery forward, which is why it's draped over the aorta like you saw. And that can cause pulmonary arterial stenoses because this is actually done, hopefully, most of the time within the first week of life for these patients. So when you see these patients, you need to be aware of those issues. And when you see a transposition patient at this time who was in their 20s, most likely this is the operation that they had. You have to take any evidence of cardiomyopathy or quote-unquote pulmonary hypertension very seriously because it could be due to either of these issues. So they are coming soon to an ER near you. So just to summarize, in atrial switch, these are still our patients who are 30 years of age and above. They can develop systemic RV failure. Be very careful with tricuspid regurgitation and be very careful with atrial arrhythmias. Take them very seriously. And then with arterial switch, be on the lookout for coronary kinking and be on the lookout for pulmonary arterial stenosis. So let's move on to our next case. So this is a very typical patient that was referred to us. So she's 38 years of age. We typically get a lot of our patients from the transplant center. So she was referred for transplant. So she had 2 surgeries that she knows about. This is kind of what adult congenital heart disease is all about, trying to figure out what the surgeries were. So she had some sort of surgery done in early childhood. She had a second surgery where she had a valve replacement with a number 21 paramount back in 2003. And now we're seeing some problems. So tell me what you see in just the brief echo images that I show you here. Right, RV enlargement. That's right, increased right ventricular pressure, which hopefully I'm going to communicate to you today does not mean that they have pulmonary hypertension, right? What else do you see? What's going on down here in the bottom left-hand corner? Yeah, it's a prosthetic valve, right? So any guesses where that prosthetic valve is? Pulmonary, right. Very good. You guys are doing great. You guys don't even need the cross-sectional imaging. Well, we did, so we got it. So thinking about it, look for, is this truncus arteriosus, atrioventricular septal defect, tetralogy of flow, or transposition? I showed you transposition, so hopefully I'm not going to show it to you again. So there's the arch of the aorta. And as we go down, there's something funny going on here, and there's something funny going on here. As we go down a little bit further, all right, so the aorta is in the right place, thankfully. There's something funny going on here. And then as we look at the orientation of the aorta to the 2 ventricles, what do we see there? And then something very interesting that's consistent with what we've found so far is a very, very thick moderator band, right? So anatomically we know that the anterior ventricle is the right ventricle. Okay, so at least that's easy. Okay, very hypertrophied right ventricle. So truncus arteriosus, raise your hand. Okay, atrioventricular septal defect, raise your hand. Tetralogy of Fallot, raise your hand. All right. And transposition atrial switch, raise your hand. Great. So that's what this is. This is tetralogy of Fallot. So this is the right ventricle, which is severely hypertrophied, both from childhood as well as now she has a very hypertensive right ventricle. This is her LV. This is the aorta, which is overriding slightly. And then, of course, this is evidence of where her prior VSD patch is. You can actually even see just ever so slightly there's some calcification at the patch. And then one of the important things that we need to look for in this particular patient is why does she have a hypertensive RV? So obviously she has a prosthetic pulmonic valve, but in addition to that, it's not just that, right? She has a stenosis in the RPA, and then she has this kink in the LPA, right? And this is actually a typical problem that we actually see. Sometimes we may actually interpret this as just a valvular problem, but it's not. You now see here that it's bilateral PA stenosis as well. So what happened? Well, so this is typically how tetralogy of Fallot works. You have right ventricular outflow obstruction with RV hypertrophy and a small pulmonic valve as well as the VSD, right? So what the surgeon has to do is cut out those RV muscle bundles, slice across the pulmonic annulus, and usually patch it as large as possible in childhood because you can't just replace the valve in childhood, right? So what that leaves us with is a situation where the patient has wide open pulmonic insufficiency from the time of their initial repair. So that mandates that almost all of these patients are going to require a pulmonic valve replacement at some point in their teens, 20s, and possibly even their 30s. So many times if they've only had one surgery and they have a diagnosis of tetralogy of Fallot, you should be aware that they're probably going to need a pulmonic valve replacement. So what does that look like? So this is one of my favorite patients, 36 years old, says he's asymptomatic. danger, okay? So he comes to see me and he says, oh yeah, you know, doc, I've got palpitations every so often. So, okay, now I'm scared. Okay, so I put on a vent monitor and sure enough, the very next day, we get a 38 beat run of VT. Okay, so why did that happen? Well, this is what his right ventricle looks like on cardiac MRI. Okay, this is what 36 or 33 years of wide open pulmonic insufficiency will do to you. Okay, and it actually looks like you have systolic bowing of the septum, but it turns out that he has pure right ventricular volume overload. So obviously his fix is that he needs that thing taken care of. So he gets a pulmonic valve replacement. They resect out that massively enlarged outflow tract. And he gets a 27 millimeter bioprosthetic valve implanted. And of course, we're gonna have a problem down the line because that's a bioprosthetic valve in a 36-year-old. Okay, so sooner or later, we're gonna have to pay that piper. So what happens next? Well, that's what happened to our patient, okay? So one of the typical problems, like our lady, is that she had her initial repair, then she gets a valve replacement. And unfortunately, this was done, I'm not sure why, she got a number 21, which is way too small for this patient, okay? So she already has suprasystemic RV hypertension, and in fact, it may be that she came out with patient prosthesis mismatch, and of course, now she's referred because her RV is quote-unquote failing in the setting of this RV pressure overload. So this is a typical problem. You put a number 21 valve, it has a true inner diameter of 19 millimeters. If we put a transcatheter valve inside this, we're gonna achieve a 17 millimeter internal diameter. So that is not a solution for this patient. So typically, this is one of the things that we'd think about doing, but we don't want to do this to her because we're just going to make her worse. So what we did instead was to actually break the valve ring. So what we did was we did a high pressure inflation. You can actually feel a click because we broke it in the cath lab. My partner in crime, Dr. Brian Holtz, did this case with me. And you can actually see the fracture, the valve ring right here. Okay, and what that allows us is to get a couple to 3 more millimeters of diameter to this patient, so we can buy her a little bit of time before she's going to need a repeat open heart surgery, and hopefully at that point her RV will be in better shape when she gets that done. So this is a sapien valve that we implanted. But of course, the story's not done at this point because she has both the RPA and the LPA stenosis as well. So we had to actually fix that. And by the time we got done, we got her RV pressure down to 50. Not perfect, but definitely far better than the 120 millimeters of mercury pressure in her RV that she had when we started this case. So typically what we want to watch for when you're looking at tetralogy Fallot is you want to be careful because many of them aren't going to have wide open pulmonic insufficiency and evidence of RV enlargement and possibly degenerating to RV failure. They are frequently subject to ventricular arrhythmias because of that severe RV enlargement. Their prosthetic pulmonic valves after their second surgery are going to be subject to PS or even PR. You need to be aware that they may have left-sided issues such as LV dysfunction as well as aortic regurgitation and aortic dilation. So let's go on to our next case. So I'm glad Dr. Breinholt didn't talk about this. This is a 38-year-old woman complaining of shortness of breath found to have RV enlargement on her initial echo. So this is not a post-op patient, this is initial presentation. What do you guys see? Gigantic RV, right? Anything else? So keep an eye on that mitral valve there. Oh, what's that? Yeah, that's right. That's right. So, okay, so this is pretty simple, right? So, single ventricle? No. Primum ASD? Great. Okay. Truncus arteriosus? Clearly not. Secundum ASD? Don't send this one to the cath lab, right? So this is a primum ASD, and one of the things that you can see, obviously, is that the valves are at the same level. So one of the things that you really want to think about when you see this kind of diagnosis is that it's a continuum, okay? So you can have this quote-unquote partial AV canal, which we often call a primum ASD, but it's really a continuum because they could have a VSD. They could have a very large VSD, and they could actually have continuity between the two valves. And within that spectrum is, of course, also complete AV canal. So you have to be very careful when you start to make that diagnosis that there are other issues underlying that may complicate how this patient gets treated. And so what you don't want to do is send this patient to the operating room without having a complete evaluation of that. So what are the complications from this? So after surgery, the surgeon may have sutured the cleft mitral valve too, quote unquote, tight and create mitral stenosis. So when you see these patients present with pulmonary hypertension later on in life, that is certainly a potential issue. If they have a residual cleft, certainly they can develop mitral regurgitation. One of the things that we've seen is this. early on in history, these patients were managed with pulmonary arterial banding, and so they may still have residual pulmonary stenosis due to the banding. And then, of course, some of them may actually have residual septal defects, which are usually typically benign. So I'm running a little bit out of time, so I'm going to try to move quickly. This is our last case. So this is a 40-year-old woman. She had multiple surgeries during her first week of life. She had another surgery at 4 months, and she had her final surgery at 5 years of age. So this one typically is hard for us to look at in an adult echo. So I went straight to showing us our venous phase MRI. Okay, so let's see what we've got here. So there's the aorta coming up. So left side of aorta. Here's our IVC. So IVC coming into this right-sided structure. So follow that right-sided structure and see where it goes. So as we follow the right-sided structure, it goes into this very small structure, right, which doesn't seem to go anywhere. Then as we follow this right-sided structure, I want you to draw your eyes to the right-hand side of it as we go up. So there's a little bit of a metallic artifact there, and it goes upwards. It keeps going. I'm going to show you what continues to go. So where does it end? So it starts to go out into the lung. So it's either a pulmonary artery or pulmonary vein. Likewise, I want to draw your attention to the SVC here. Okay, so what happens to the SVC? The SVC, as we go posteriorly, goes to vessels going to the right lung. Okay, so then let's look at this ventricle here. Okay, so you have a ventricle that's connected to that arterial structure, and the arterial structure goes, we don't have the coronaries because we don't have the resolution for it, but it goes down to the descending aorta. Okay, so we have our systemic ventricle. So what are we looking at here? Is this single ventricle? Raise your hand. Is this primum ASD? Raise your hand. Is this truncus arteriosus? Raise your hand. Is this secundum ASD? Raise your hand. All right, we finally got one that stumped you. Okay, so in the interest of time, I'm just going to walk you through this again, right? So what we looked at here was we have an IVC that terminates into this atrium, okay? And then here you see there's the structure here that's really tiny. It really is kind of muscular as you look out into what should have been the apex, but it doesn't form the apex. So this is sort of what some people call hypoplastic right heart, but in fact it's actually tricuspid atresia. It's hard to see what the tricuspid annulus looks like. And then what we see is a systemic ventricle that actually has papillary muscles very nicely, and it's actually her systemic LV. Then what we see is this is a very old style, what we call fontan. And what it is you have the IVC that goes to the right atrium, and then the right atrial appendage is connected to the left pulmonary artery, okay, right out here. And then we see that the SVC is connected to the right pulmonary artery, right here, okay. So this is what we call a cavo-atrial fontan. And so initially she had shunts, then she had a Glenn, and then she had a final surgery. So this is single ventricle fontan circulation. So this is typically what we're dealing with, right? So we have an absent right ventricle, and the systemic LV has to do everything at birth. And so what we first have to do is find a way to actually create a PDA. So oftentimes the patient has to undergo a shunt of some kind. And these can be called a bleloctasic, Waterston-Cooley, central, POTS, Seno. These are all the things that you want to look for when you're thinking about the history of these patients, because a lot of times these patients have no idea that they're a single ventricle patient. And then, of course, the second surgery is the Glenn shunt, in which the SVC gets connected to the pulmonary arteries. And then the final is the fontan, in which create the final pathway where we bring the IVC to the pulmonary circulation. And so there are three different types of this. There's the cavo-atrial fontan, which our patient had, which is a little bit older. We had the extracardiac fontan, which is what's depicted here with a graft. And then we have the lateral tunnel fontan, which uses part of the atrial tissue to make that the case. So the things that you always have to watch for in these patients, who are very complicated, is that they can, of course, develop systolic heart failure of their systemic ventricle, especially if it turns out that they use the right ventricle for that. One of the things that's very concerning is protein-losing enteropathy, and this you can identify when they start to develop diarrhea because they're losing protein into their stool, but also when they have a very low albumin. Usually by that point, however, they're very sick already. These patients are subject to liver failure, which is a uniquely fontan issue. They can have cirrhosis that is undetected, and they can even develop hepatocellular carcinoma. And then finally, because of the way they were built, they are often subject to hemoptysis. So that's pretty much my time. So what we talked about today is D-Transposition of the great arteries, in which I want to really emphasize looking at the coronaries, especially when you're looking at arterial switch patients. Tetralogy flow patients, I really want you to look for pulmonic regurgitation, especially if they've only had one surgery. Atrioventricular septal defects, one of the things I really want you to look for is mitral lesions in these patients who've probably had their mitral valve operated on. And then finally, Fontan. There are a number of mechanical issues as well as protein-losing enteropathy and Fontan liver failure. So the last thing I want to leave you with is always beware of asymptomatic because they don't really know what that is. So I'll skip the bonus round because I'm out of time.